Good day. I am Eleni Efstathiou, and thank you for joining us in this e-cancer review of the data that was presented during this last ASCO with regards to advances and prospects in the therapy of patients with non-metastatic and metastatic castration-resistant prostate cancer. We have the pleasure and honor to have in our company three very esteemed colleagues from Europe. I am Eleni Efstathiou, also from Europe and the United States. And I would like to turn to Stefan Oudard, a person I would like to call a friend, apart from an esteemed colleague, to have his introduction, then to Dr. Boris Hadaschik, also a urologist from Germany. And finally, Dr. Attard, as I see you, I mean, there's no rhyme in how as I see you on the screen, to present yourself before we embark in our discussion.
Thank you, Eleni. So my name is Stefan Oudard. I'm a medical doctor. I work in Pompidou Hospital in Paris, France. And I'm really happy to be part of this discussion on the ASCO GU meeting, which unfortunately was not a face-to-face meeting, but nevertheless, nice and interesting things to look at. And
Boris.
Hello, Stefan. Hello, Eleni. Thank you very much. Yeah, my name is Boris Hadaschik. I'm a urologist based in Essen in Germany, and I'm very happy to provide a urologist or surgeon's perspective to our discussion.
And Gert, we go way back with Gert. We started together, I think, right? So
yeah, many years, at least 15, I think, Eleni.
Yeah.
Since we
13. Don't give us more. We don't want to be old here.
I think we were both awarded a Young Investigator Award from the Prostate Cancer Foundation, 2008. And always good to discuss the abstracts. Thank you for inviting me. My name's Gerhardt Attard. I'm a medical oncologist in University College London, and I guess the third medical oncologist on the panel. We are outnumbering urologists. We need to address that for the next discussion.
And we've turned the tables. It wasn't like that. So I think we need to find a balance again, Boris. So I'll be turning to you a lot for your thoughts, because this is not about who's going to take over. This is about all of us sharing the knowledge and making the most for our patients. So with that in mind, indeed, as Stefan pointed out, we've been really doing all this from the confines in our home, our office. We're able to more interact now with our own practice, and apart from Zoom meetings like this. So sometimes this leads to a little bit of an isolation that is concerning. The whole idea of these big meetings was to come together, to exchange ideas, to get the real vibe of what we think about what was presented. And now, if we follow it through Twitter, you see, those of us who do, that people walk away with their own impression, and there's not the opportunity for a lot of dialogue. So we're trying to fix that a little bit through these meetings, I believe. And with that in mind, let's get started with the non-metastatic data. And when I say non-metastatic, turning also to Boris Hadaschik, who is a person who has been all about novel imaging, apart from his other work, you didn't mention that, Boris. I want to stress that we're going by non-metastatic with the conventional term, by conventional imaging, not by enhanced and novel imaging modalities. So not a lot of data presented with regard to non-metastatic. Boris, I think the main presentation that had to do with clinical kind of assignment of treatment paradigms was the analysis of the crossover patients in the ARAMIS trial, meaning the patients who, upon unblinding, were offered darolutamide when they were on placebo. And the comparison, even though I believe it was post hoc, of those outcomes as compared to those patients who are early on. We know well that in the Spartan trial, this was done a priori, thanks to the PFS2 exploratory endpoint. But I'd like your thoughts on this ARAMIS presentation, because it's an issue of reproducibility and reinforcement of what we already know.
All right, so if we remember, nmCRPC is a niche, and we had 3 big phase 3 trials with the primary endpoint of metastasis-free survival. And then later on last year, we got the presentations of overall survival benefit, and all 3 trials showed really remarkable efficacy of treating early, so before there are metastases on conventional imaging. And there was an improvement of roughly 2 years with all of the 3 drugs in MFS. So the overall survival data are a little bit less mature, but they also point out a big 30% difference in overall survival between men receiving treatment early and men receiving treatment only at time of metastases, so mCRPC. And in the Spartan trial, in which I was involved in, we did an analysis to account for crossover, because in Spartan, which is an older trial than ARAMIS, the time there were patients on placebo at time of the final analysis was more than 2 years. So we saw an improvement in the hazard ratio when we accounted for crossover. Now the data presented here by Neil Shaw on ARAMIS did not show a big improvement if you account for crossover, but this is, in my opinion, based on just a lot of shorter time that men had in the crossover portion. So the remarkable overall survival difference of darolutamide of 30% remained stable despite accounting for crossover. So I think this is reassuring, and interestingly, the hazard ratio of 0.69 of ARAMIS compares well to the crossover adjusted hazard ratio of 0.69 in Spartan. So I think all 3 drugs are good, and they just reinforce that early treatment in this patient population makes sense, because we know, and we have to remember, all of these men have a short PSA doubling time. And if you use other imaging, for example, we know these men have much more disease than this M0 on conventional imaging.
Thank you for that very, very detailed explanation and reinforcement of the fact that the data is reproducible. We're not going to handhold anyone to decide which one is their choice. A lot of it is based on your experience with patients, of course. And as you very clearly said, Boris, we're all involved in different trials and have our own experience with using these data sets. I don't know if, Stefan, you wanted to add something with regard to the nmCRPC space. It's still a difficult space, and a lot of people are still asking, now that we're using more and more enhanced imaging, or if we have a local disease that is recurring and we've exhausted radiation, for instance, what do we do? Should we still rely on these data sets that came from these 3 trials, or should we look further? Do you have anything to add to that?
Well, if you look at the Spartan, study, well, all these 3 studies in fine are great, and outstanding in terms of outcome, regarding MFS, and in the Spartan, study, we have, update, regarding maybe exploratory analysis regarding the biomarker analysis for those patients, and they try to find out, to separate, long-term responder to early progressor, to find out if you have any different signature for those patients, and they perform, a signature characterizing into 3 general mechanism classes, either immune regulation, proliferation, or hormone dependency. And they found out for those patients with long-term responder that they have increased immune activity, they have decreased vascularization of the tumor, and also proliferative of the tumor cells capacity at baseline, which is associated with good outcome. In the contrary, for early progressor, it seems that they have a kind of basal, component of the tumor, as well as their neuroendocrine-like tumors as well. So maybe so far it's not possible in daily practice. Maybe we could have some information regarding those patients who benefit the most from this new hormonal therapy.
So thank you, Stefan, for the comment regarding the efforts of reaching that holy grail of being able to identify early on who are going to be the big winners with specific treatments. And I'm going to hold that thought because we're going to dedicate a little bit of a bigger part of the discussion, I think led, I would say, by Gerd, regarding this effort to refine and identify biomarkers that would lead us to that precision that we really, really need as a next step of our development, right? That's where we're lagging in prostate cancer. With that in mind, I want to move over to mCRPC, and just a brief comment from Boris. Sorry to go back to you on that one. We saw one big trial, it wasn't small, it was, I think, 200 patients from the Asian population, which was addressing the obvious, something that we are looking at like, is this still a question? We know that in Asia and other parts of the world, even I believe in South America, there is still that view of life that we should use first generation anti-androgens before we move on to second generation enhanced androgen signaling inhibitors. With that in mind, we see patients being treated with bicalutamide still early on, and then moving on to flutamide. Full disclosure, I haven't used bicalutamide apart from that first induction period when we use an LHRH agonist for years. So I'm the least, specialist to speak on that. But Boris, your thoughts on a little bit on that trial, and whether you think the answer is here and we should no longer challenge the tumor with these approaches.
All right, so my disclosure is that I sometimes do use bicalutamide in the context of salvage radiotherapy because of the Shipley data, but I have not used flutamide for years. So, but as you correctly pointed out, there are regions in the world where it is still used, and it's much cheaper than the newer generation drugs. So I think there's a reason, and so it's important that now from Japan we have this phase 4 study called AFTERCAP, where they compared enzalutamide to flutamide in men with asymptomatic or mildly symptomatic castration-resistant disease. And there is a clear improvement in outcome and PSA progression rates with enzalutamide over flutamide. So I think we can really put this question to rest. If you have the newer drugs available and they are reimbursed for, there is no reason anymore to change between first generation anti-androgens, and I don't see any space anymore for flutamide. And
when everybody kind of asks, no, but we do it, we'll just show this trial and we'll be done with it. So, but let's move to the big deal of this ASCO meeting with regard to clinical data presented. We usually look to phase 3 trials to get a reaffirmation of what we believe would be the future. And I'm going to actually just say right off the bat that all three of us medical oncologists were part of this phase 3 trial that was presented. We were PIs. We were even listed in the co-authorship. I'm referring to the ACIS trial. This is a long anticipated trial. I remember initiating this trial in my institution in 2015. The data took much, much longer to mature than we expected, 6 years. And this is usually a good thing. It means that our patients are responding and potentially to both arms. And it's a good thing overall for the space, for mCRPC. Never would we expect back in 2007 that we would run an mCRPC trial that would take more than 6 years to mature. This was a trial in the space of mCRPC where patients were offered ADT plus abiraterone with or without the addition of apalutamide. The primary endpoint was just rPFS as defined by the PI, the investigator who was treating, and secondary endpoint was overall survival. So I'm going to turn to Gerd to get his thoughts, then hear from Stefan and his experience. And finally, I'd like a comment from Boris on the results as the independent reviewer who was not part of the trial. Gentlemen.
Yeah, I think you've introduced this well, Eleni. The primary analysis, which would have reported about 18 months ago, I think, was to define rPFS, but the IDMC recommended not reporting at that time. So this is the final analysis, which, as you said, is about 2 years later than we expected the first report. So the first report of the trial, but includes both the primary analysis, which actually was positive, and this final analysis. And the primary endpoint rPFS, a very significant benefit for the combination of apalutamide plus abi versus abi alone, which I think proves the hypothesis that dual AR targeting is more effective than single AR targeting. The question now stands that with subsequent treatment with an AR targeting drug like Enza or APA, recover or salvage the benefit and result in an overall stable overall survival. And I guess the trial has not addressed that. OS was a secondary endpoint. There is a numerical benefit in terms of survival for the combination versus abi alone, but that is not statistically significant, and the trial wasn't designed to answer that question. So the jury's out. The second question that now arises, and that you asked me about earlier, is in the HSPC setting. And repeatedly, we've now seen that a more effective treatment when started at start of ADT has a greater magnitude of benefit in terms of overall survival. And I think the data would support that is maintained even when that effective treatment is used later. So earlier treatment with docetaxel, with the AR targeting next generation drugs, improves survival that is not salvaged by later treatment in the CRPC. I think the only trial that will address that, or that has recruited patients to address that, is the Stampede trial. There was a comparison of 2,000 men randomized between abi-enza plus ADT versus ADT alone. And that trial has a primary endpoint of OS. That trial should report probably in the next 12 months. It's event-driven and was powered to hit the events, I guess, in the next 6 months or so. But just a footnote, I guess, I was explaining earlier, I'm very involved in the Stampede trial, and in fact led that comparison. When we designed it, we aimed to show a difference versus abi alone in an indirect meta-analysis, because patients are not concurrently randomized to abi ADT or enza ADT versus abi enza plus ADT. And this is an academic trial, and I guess you have to allocate resource in the best way possible. And the statistical analysis plan was powered to detect a difference if the benefit for survival with abi alone was about 0.75 hazard ratio. Now, with a hazard ratio of 0.63 showing a superiority in an indirect comparison in an unselected population, it's going to be statistically challenging. So, to be honest, I'm still mulling over how best we use or interpret the data from ACIS. I guess it certainly increased the relevance of that question. And over the next 6 months, we'll need to think really carefully how we'll interpret that data now in the context of this positive result in ACIS.
So, thank you. I'm smiling listening to you, because we've had over the years, all of us had these discussions from those first presentations combining abiraterone with enzalutamide back from now 2012. And I'm going to turn to Stefan with that question, because you really pointed it out, Gert, saying that even numerically, we see that benefit in the combination in OS, suggesting that we might reach a point where we are able to define which group has this very extreme androgen signaling addiction where one is enough, versus the group where you need to combine, versus a group that it doesn't really work, are known as primary resistance. And that's going to be our next topic of discussion based on this initial Spartan data set that Stefan mentioned. With that in mind, and taking into consideration what people in the community are saying, hey, you guys, you're going to ask me to do 3 drugs, ADT, apalutamide, abiraterone, or enzalutamide, or darolutamide, or what have you. What's the safety there? And what's the proof that I'm actually serving the therapeutic index, meaning efficacy over safety? Stefan, your thoughts. Will this transcend to a real practice eventually?
Yeah, I agree. I agree with Gert about the fact that the primary analysis was blind, because our PFS was 6 months at the beginning and then moved to 7.3 for 4 months at the end. So maybe for OS, the OS data maybe move as well, with mature data. This is my first point. Anyway, the study is positive in terms of according to the primary endpoint. So this is a good point. The second point, as you said, about toxicity. I don't know in the real life what is going to happen to the patient with maybe more comorbidity and so on regarding combination. And the third point is about, should we go for combination or sequencing? This is really the point, because we need to look at PFS2 and to see whether or not, you're with the combination, you don't induce complete resistance to further treatment so far. And this is not well understood so far. So we need to look at that. And so the question is there. If you look at the Alliance study from Michael Morris, the PFS was obtained 4.5 months, no benefit in OS. So what should we conclude at the end? Should we go for combination right away, or should we try to sequence as well on specific patient population? And this may lead to introduce about, which patient could benefit the most, maybe patient with, I don't know, liver mets or luminal versus basal, a subtype. We need to see which patient could benefit the most from that.
Thank you, Stefan. And indeed, Alliance trial was positive for our PFS, negative for OS, but OS was a primary endpoint there. So that's the problem. And here go my peacocks again, apologies for that. But Boris, one quick thought on whether you think this will be, under circumstances, practice-changing study, and what would convince you further?
So I think at this point in time, it's not a practice-changing study, because since 2015, things have changed. And especially now in COVID, I think first-line treatment in hormone-sensitive metastatic disease is already an androgen receptor signaling targeted agent. So we don't give right now docetaxel in first line. We tend to use one of the new drugs. And I think the hazard ratio now, the updated one with apalutamide for all comers, is pretty convincing. And so that makes things for then first-line mCRPC challenging. And ACIS was first-line mCRPC. Now things have changed because we deal with a different patient population. So I'm waiting for the data that Gert is going to present. So this would make a difference for me in the hormone-sensitive setting. But until now, it doesn't change anything, because we are not able to stratify men at this point in time in a, for me, convincing and practice-changing way. But in Germany, biomarkers are a little bit more difficult than imaging. So I'm looking forward to results of you, because I know you look more at biomarkers than we do.
Well, as you said it very nicely, Stampede is going to come again and save the day. You guys have been doing it since 2015, right off the bat, from the first data that confirmed charted. And since that time, you kind of led the way, and thank you all for that. And I want to move on, in the interest of time and our viewers, to one little comment. And I'll take it back to Stefan. Stefan, you mentioned a little bit about sequencing, and we thought we put it a little bit to sleep after we looked at this great hard data, suggesting that you should not sequence androgen signaling inhibitors in the setting of mCRPC, and that you should transition to another mechanism of action, aka cabazitaxel. Wonderful study, again, disclosure, I was part of it. But we saw data presented that suggest that there are efforts to look at novel androgen signaling inhibitors yet. There were 2 abstracts presented. I apologize, I'll have to look at my notes for it, because a name has not been assigned, is GT0918 of the new anti-androgen. And there were two abstracts. One was a phase 1 that was done in Asia, and then a phase 2 US experience where they are transitioning from prior ABI or ANZUP treatment to this new agent and showing some initial data. My question to you is not to comment on the data, but now we have 4 novel androgen signal inhibitors and the space is getting crowded. I'm not the right person to comment because I said the same thing for darolutamide and I was the fool, right? Darolutamide is alive, kicking, and doing very well. What do you think? Is there more space for further refinement in the androgen signaling treatment space?
So maybe I would say yes and no. Yes, because regarding side effect, maybe we could find a new drug which do not cross the blood-brain barrier. As we know, maybe darolutamide is greatest, in fact, in not inducing this kind of neurologic side effects compared to abiraterone or apalutamide. But maybe if we can find, new drug without any problem regarding neurologic, problems so far, it could be great. And maybe to be also maybe greater at the androgen receptor level in terms of efficacy so far. So it could be also a good point. But nevertheless, it's going to be difficult for the laboratory to, to go ahead and to put the drug in as a good comparator, later on, because as you said, the space is already completely crowded so far. So yeah.
Right. It was more of more of an overview question because this specific agent, by the way, let's comment on the fact that it looks like, though it doesn't pass the brain barrier, it does have an adverse effect with regard to concomitant treatment with lipid lowering agents, with toxicity, liver function tests, elevation, and the like. So we'll look for more data on that one. But I wanted to press the point about combinations in mCRPC that are still being pursued, and especially with regard to that holy grail of finding that sweet spot where we can use immunotherapy to treat prostate cancer. We're still failing to help a big percentage of our patients, even though we see those magic responses in the space of tumors with MSI or high TMB. So your comments, Stefan, since I've got you here, on what was presented and what the future holds from what we saw in GU ASCO.
So I think that regarding immunotherapy, there is two studies so far, the Keynote study and the Checkmate study, looking at either pembrolizumab or nivolumab with docetaxel so far. But we don't have yet, the biomarker to select those patients because, as you said, it's a elderly patient population with comorbidity and so on. So we don't want to add too much toxicity. And in these two studies, if you look into details, you will see that we had some deaths due to the immunotherapy, 3 in the first one and 2 in the other one. So 5 patients dying from the immunotherapy in this clinical trial. So immunotherapy to chemotherapy will add anything at the end, because if you look at the data, it doesn't seem to me that really it's outstanding in terms of efficacy, PSA response, and so on. But I think that we do not select well those patients. You said that we should maybe select our patient based on the MSC status, but as you know, the MSC status is only 3% in prostate cancer, so it's going to be tough to select the right patient for those clinical trials. So now I think that I'm not completely convinced about the fact that to combine and to see whether or not it's better. But so far there are a lot of phase 3 trial ongoing, and I'm not sure that the result will be a positive, positive data.
True. It was really confusing to me to see so many efforts, but a lot to expect in the future. And I want to turn back to Boris, because we said phase 3 trial that was presented during this trial, ACIS, really the high point of the presentation with regard to clinical data set. But Boris, you mentioned earlier before we started this meeting that it would be amiss to not go back to the big expectations, the expectations on the therapeutic PSMA lutetium. Would you like to comment on what was presented during this GU ASCO? And are we closer? I know you guys have it, and I turn to you because I know in Germany you've had access, but the rest of us don't unless it's within a trial. So what does the data tell us, and how soon will we have something that's in our clinic?
Right. So yeah, I do share Stefan's skepticism with regards to IO at the current time. And I think with lutetium PSMA, we have this radioligand therapy that is really promising and that is used in third-line systemic treatment in Germany on a routine basis because we have reimbursement. And now at this year's ASCO GU, we have an update from Michael Hoffman of the TheraPs study. So a study of men with mCRPC post-docetaxel, and these men were randomized in a phase 2 setting to compare cabazitaxel versus lutetium PSMA radioligand therapy. There was a good patient selection, and I think that is important because all these men have had to be PSMA positive, and at the same time, there was not allowed for FDG mismatch. So if there are heterogeneous tumors that have high FDG signal, but low PSMA signal, these men were excluded. And if you have this careful patient selection, the data that was presented on lutetium PSMA was really nice, showing a doubling in PSA reduction and progression-free survival as compared to cabazitaxel, which is a strong comparator. So I'm really happy, but certainly we have to acknowledge that the OS data is not mature yet. This will probably be reported next year. And the exciting theme of this year for lutetium PSMA will be the VISION trial, a phase 3 trial, where lutetium PSMA serves as an add-on to ongoing therapy. And this is powered for overall survival. And I'm expecting it for ASCO. So I think this will broaden our armamentarium. And I'm a strong believer that this therapy will have its place. I don't know whether it's third-line mCRPC or in the future a little bit earlier. We have to wait for that, but it's definitely promising and it's easy to handle if you have good nuclear medicine colleagues.
Okay, we now know that you're a little bit partial towards lutetium PSMA. We got it. So, but honestly, we're all super excited, and you made it even more, you know, on the edge, waiting for the data. And I'm going to turn now, because you did mention earlier, Boris, that it's going to be important to get biomarkers, and biomarkers are not just molecular assays. They could be more. It could be like what you described that Dr. Hoffman did. But I want to turn to Gert, because I know his life's work has been pursuing biomarkers, and get, Gert, your thoughts on the data set from an mCRPC to CRPC that was presented during GU ASCO, and how it can further our efforts to refine biomarkers that are going to be predictive of outcome and maximization of that therapeutic index across the board, and where you think we're going. Where is it going to transcend to reality that's practical? Boris said a lot of us don't have access to these very, very, let's say, complex assays. What do you think, and what do you expect?
So molecular biomarkers, and as you said, Eleni, the focus is on prediction in CRPC. So should I use drug A instead of drug B, or patient selection? And most of the, I guess, DRD for PARP is a treatment selection rather than A versus B. So there's as at every meeting, I guess, for the past decade, multiple abstracts on biomarkers. We're discussing probably 4 here. One that Stefan's already mentioned, presented by Felix Feng on the Spartan trial, and then one from the IPATential trial presented by Johan de Bono, and then 2 from the Olaparib trial. And the I guess what comes to mind, the lesson to learn is no biomarker is perfect. And it's a balance between ease of use, ease of reporting, cost, and maximizing the target population. And you know, there's a number of I guess, settings I've been in where we've discussed biomarkers and we've been really purist and we're pushing down the target population to 1%. And then we think about how on earth are we going to run that trial? How are we going to fund it? So there, behind the scenes, there is this balance on the spiraling upward cost as purists try to choose the perfect biomarker versus maximizing efficacy or observing enough efficacy to have a positive trial. And briefly on the Spartan data that Stefan's already talked about, identifying this hormone insensitive population. We've seen similar data from the Titan trial using whole transcriptome. And again, similar data on ACIS using whole transcriptome. And I think there's, they're all in subgroups of these large trials. So the analysis have primarily been in subgroups of the trials, but they're building a story. And increasingly putting all these trials together, although none in isolation is to date clinically changing, I think the case will get there that we will start to introduce subgrouping of patients based on their transcriptome profile and probably this hormone insensitive group. So that's the first piece, which I think is the one furthest away, but I really see the story developing. The next is IPATential, which, as I said earlier, I think is a beautiful human experiment, a beautiful trial, because it's proven what was previously observed in preclinical models, that co-targeting of AR and PI3K-AKT is more effective than targeting of AR alone. And that was done in a xenograft model or a genetically modified model. And to take that into humans and observe the same effect is a massive leap. Now, the question is, what is the best biomarker? And clearly, you can see that balance I referred to earlier between a very pure biomarker that confirms activation of the pathway and maximum efficacy versus one that can be implemented. And showing there is a genomic change is possibly more robust than a protein change, but you lose a lot of patients because of the challenges of performing next generation sequencing. And because not all modes of loss of PTEN occur through a genomic event. So in this reanalysis, where there were multiple cut points for the immunohistochemistry test to define PTEN loss, and there's the use of NGS, basically the stricter you are, the better the hazard ratio, the greater the benefit for combining IPAT with ABI. And it's certainly food for thought. These are all postdoc and they're all exploratory. And that leads me to the second challenge. No biomarker is perfect. And how do we use data on an imperfect biomarker in our clinical practice? So when we see a positive result, and we saw a positive result with the first report of IPATential, and then we see subsequent reports where the biomarker is refined that are postdoc and exploratory, how do we use that data? It reminds me through what we're going through or have been through with radiotherapy to the primary tumor, which was based on bone scans and CT scans, low versus high volume, probably an imperfect biomarker, but we're sort of stuck with it because that was what was predefined. And are we stuck with that here? And how do we break that mold, I guess, while keeping within statistical rigor? And finally, again, in this vein, the analysis of profound, exploratory, and looking at specific response rate by gene type, where, again, the greatest benefit is for the BRCA groups. I think the benefit in ATM remains limited. And hypothesis generation for other gene subtypes. And I think we'll get to the point in a few years' time, once multiple trials of PARP inhibitors report, where we can then start combining these data sets and understand what the true response rate in a reasonably large group of PALB2 mutants, for example, is to PARP inhibition. And I hope we will be enabled to do that. And the final abstract is relates to ctDNA and whether we use tissue or plasma DNA. And there is some discordance. So patients who were positive on tissue were not positive in plasma. And I think that's probably primarily to tumor shedding into blood or metastatic volume. So if there's not enough tumor in plasma, then one's not going to detect the aberration because it's there's not enough of a tumor fraction to hit that cutoff. But overall, I see high concordance. And personally, if I detect an aberration in plasma, especially BRCA, which is what PARP inhibitors are licensed for currently in Europe, I would offer that patient a PARP inhibitor based on a BRCA mutation solely in plasma, not in tissue.
Excellent overview. I'd like to add a couple of comments on your thoughts. First of all, we have this effort that you mentioned, this effort to increase the statistical significance of our findings sometimes might end up leaving out some patients that would benefit. And I had this experience through my recent presentation in the ASCO meeting where I was looking for that signature in the diagnostic biopsies, and I realized that the more stringent you become, yes, you increase the specificity of your finding, but you lose sensitivity by definition. So we might end up not giving the opportunity to patients who would benefit. And that is a very fine line that we'll need in the future to address. One more comment that was brought up by Boris, and I believe Stefan, is also the access to these specific assays. So yes, immunohistochemistry is faulty, but we have relied on it for so many other solid tumors. We should be able to deliver something to the community before we are able to move to what is a highly, highly sophisticated assay for now. And final comment on this, you mentioned in the beginning, the great value of actually having concordance between experimental conditions and the delivery of the human result of the clinical experiment. A big shout out, I would say, is deserved to Charles Sawyers, who did that first work, and over we've seen him deliver across the board in oncology, and one of my favorite, of course, scientists, I have to say. So we don't have a lot of time, but I want to hear back to Boris and Stefan your thoughts on what was presented with regard to the value of androgen deprivation in the era of COVID and protection from infection or gravity of infection. There were even some efforts to provide ADT to men who were not patients to protect them in the beginning through the story of Tempers 2 and the affinity with the invasion of COVID. So your thoughts, especially in view that we're getting great data now supporting that maybe even one shot of the Pfizer vaccine could be protective as high as 92%. Do you think there's value to think that our patients with ADT alone are protected?
So from a urology perspective, I think, we were all excited with that Italian data last year that suggested that ADT might be protective. I think with the data now at ASCO, which has limitations, but a man on ADT cannot feel safe. So the normal advice to behave safe has to stay there. And I think what we learned in this COVID times are a couple of things. For localized disease, it's uncritical to delay curative intended radiotherapy or surgery for a couple of months. The other part right now is that we really have to encourage people to get vaccinated. And there's a lot of discussion in Germany right now with the different agents. And my recommendation is whatever is offered to you, get it, because it's really a huge improvement against not being vaccinated. And so in Germany, cancer patients get prioritized a little bit. They get vaccinated earlier. So this is a chance for our patients. But with regards to ADT, it does not change any of my recommendation. If a man needs ADT, he gets it. If he doesn't need it, he doesn't get it.
Yep, less is more there. Stefan, your thoughts?
Yes, so we had this previous, article showing that ADT could prevent, the appearance or the severe COVID-19 symptoms for 2 patients. So far in these 3 abstracts, they're all negative regarding, the activity maybe of TMPR SS2 and inhibition with ADT. So, we need to take into account these 3 abstracts, but they have some biases so far based on comorbidity and communication as well, because we know that for obese people, for people having high blood pressure and so on, and diabetes maybe, we need to see if, the group are well balanced in terms of characteristics so far. So we need to see, maybe the answer is not yet completely done. We need also to look at the testosterone level of those patients as well. So, but there is a rationale, I think, to my mind, to maybe to continue to go further, because if you can block, the TMP pathway, I think really it's useful as well in prostate cancer, so for COVID-19. So the hypothesis is really interesting to look at.
Absolutely. So exciting year ahead. Hopefully we're going to be able to interact in person. Back at least ESMO, I'm just hopeful, even though sometimes it becomes a little bit more dire than what we would want. Thank you so much for sharing your thoughts. Thank you all for watching us. And to more data that is very exciting and will change the lives of our patients. Thank you very much.